up the slide for the first debater, Dr. Sanjay Adla, sir.
Thank you. And actually, I request Dr. Sanjay. He is a consultant uro-oncologist at Apollo Cancer Center, Hyderabad. And he is actually very well known. He is trained from mainly robotic surgery, UK trained, and he has done a lot of robotic procedures. And I think he will be, his lecture is in robotic surgery. We know robotic surgery is actually, there's a lot of advances in malignancy, like in medical oncology, targeted immuno now, in surgery, precision surgery, less hospitalization, less hospitalization, less blood loss. So whether robotic surgery will replace traditional surgery or not, Dr. Sanjay will be speaking. This is a debate actually.
Thank you very much, sir. Thank you very much to the organizers to invite me all the way from Hyderabad to make a case for robotic surgery, which is very close to my heart, and I'm sure to my fellow debater as well. Okay, so I don't know whether you followed the news. Last week there was this news everywhere saying that this gentleman had a surprise birthday gift. And the birthday gift was a skydiving birthday gift. So he went up in the aeroplane to the top. And then he had a backpack on when he was there. And then when he had to jump out, he was said, "Oh, please take your backpack off, put your parachute on." Then he said, "Do I need to use a parachute? What is the evidence for it?" And then everybody looked at him and said, "You don't need evidence for putting a parachute on your back. That's common sense." But anyway, we said we'll find evidence for robotic surgery, which is easier. In the interim, we'll find evidence for using the parachute. So I'll give the answer to this at the end. Radical prostatectomy, the commonest robotic procedure we have been doing using the robo. And when you look at the history of it, it's been more than 100 years we have been doing it. Defined in 1905, and then everybody was doing it wrongly until 1980, when we understood actually where the prostate was. And then 2001, so that is 22 years ago, when we came across this robotic radical prostatectomy. And then this paper in 2018, which said that actually robotic radical prostatectomy is no different to open radical prostatectomy. So we'll jump in and have a look at this paper. This is an Australian randomized control trial. Rarely do we have randomized control trial in surgery. There is no randomized trial, or there is one comparing lap cholecystectomy to open cholecystectomy, but everybody does lap cholecystectomy. Okay, so let's look at this phase 3 randomized control trial. Numbers, not huge, which is typically surgical, 160 in each, and done by one surgeon doing robotic surgery, one surgeon doing open surgery. And what they found is, I know the slide is busy, but I only want you to see the p-values, saying that actually there isn't any difference. Okay, so at 6 weeks, there is no difference, and there is no difference at 12 weeks, saying that open surgery is equivalent to robotic surgery when you look at the quality of life of these patients. Again, at 6 weeks and at 12 weeks. Then you ask the question, why would a robot make a difference to these people at 6 and 12 weeks? It doesn't. It makes a difference initially. So is it an RCT? It isn't an RCT. It's a comparison of one surgeon against another surgeon. There were only 2 surgeons. The robotic surgeon was younger, only into 2 years of practice, has done around 200 prostates, going against somebody who has more than 1,500 open radical prostate. There is no one in India who has done, I think, even more than 500 open prostatectomies. So you can see that the comparison was against somebody very experienced. Does that make it that still it was equivalent? Robotic surgery was equivalent, it wasn't inferior. So the randomized control trial said it is non-inferior. It wasn't superior, but it is non-inferior. But the question that we need to ask is, are we measuring what we should be measuring? At 6 weeks, robot doesn't make a difference. It makes a difference initially. If you see there, it takes shorter time to do robotic surgery. There is less of peroperative events. There is less of bleeding during the operation. There is shorter stay in the hospital. That is where the robot makes a difference. It doesn't make a difference at 6 weeks or at 3 months. It decreases the morbidity which is peroperative. And when you look at the pain, so patients sitting, there isn't any difference, but when they start doing any work, it is much better for patients who have robotic surgery compared to open surgery. These are the variables that we should be measuring. Do I have any evidence to say that actually it makes a difference? So this is an 8-year-old follow-up from Sweden. The good thing about Sweden is even if you cough twice like that, they would be there on a register. So everything is recorded in Swedish cancer registry. So what they did is they followed up patients who underwent good numbers, open prostatectomy and robotic radical prostatectomy. And what they found, so this is dividing them into low risk, intermediate risk and high risk. So these were patients who underwent the surgery, and what you can see is robotic surgery, this is positive surgical margin, it's lower when you do robotic radical prostatectomy. It doesn't make a difference in low risk and intermediate risk, it makes a difference in high risk. Biochemical recurrence is lower with robotic surgery in high risk compared to the other two. The other two, it's equivalent to open surgery. And what that does do, when you do operationing in low risk, whether you do robotic or open, doesn't make a difference. Intermediate doesn't make a difference. In high risk, robotic surgery is better with respect to cancer-specific survival. So it makes a difference where it does need to make a difference. Radical cystectomy, new kid on the block. We started with prostate, then we moved on to partial, then we came the cystectomy. But cystectomy has got 2 trials, randomized control trials. Partial nephrectomy even doesn't have 1. So that's the reason I'm covering this radical cystectomy. This is RAZOR trial from USA. Again, similar numbers, 170 in each group. Robotic radical cystectomy, extracorporeal ileal conduit. So they did the surgery robotic, but they reconstructed it extracorporeal. What did they find the difference? There is no difference at 3 years with respect to cancer survival. And the answer is, why should there be a difference? Robot is non-inferior to open, and that was the outcome from the RAZOR trial. But when you look at the perioperative outcomes, you can look at the blood loss, less with robotic cystectomy, intraoperative transfusion rate, less with robotic cystectomy, length of stay shorter with robotic surgery. This is the IROC study from England, again looking at the same thing but looking at with a finer comb, 338 patients. And what you see is that survival wise doesn't make a difference, but when you look at the quality of life, robotic surgery is much earlier return to activity compared to open surgery. Partial nephrectomy, systematic review of comparative trials, and what it said is operating time is same, warm ischemia time is same, positive surgical margins is only difference comes estimated blood loss. Again, it's non-inferior. This is my own study, my comparison of open versus robotic partial nephrectomy that was published, 82 compared to 108. Again, there is no difference when you look at all of them. Ischemia time is similar, overall complication rate is similar, length of stay 2 days versus 5 days. So robotic surgery oncologically is equivalent, that's a primary outcome. Secondary outcome, robotic surgery is better compared to open surgery. Now, what is the evidence for Dr. Gupta to come off the aeroplane? So we found a randomized control trial that looked at using of parachute when you jump off an aeroplane. And what did they do? Jumping from an aircraft, both aeroplane and helicopter, okay? And they did, this is the concert diagram. They had recruited quite well, randomized them, and the outcome were quite simple: death or major traumatic injury when you jump off an aeroplane without a parachute. And they didn't find any difference. And this was the outcome. Results, there was no difference. Okay, then we said, can we have some more information on it? Can we have some pictures of people jumping off? And this is what they were doing. Nowhere in the study it said that the aircraft was flying. It was on the ground. Okay, and that's what whenever you do randomized control trial. So he had this information and he made this jump. Absence of evidence is not evidence of absence. It is for us to find out. Robotic surgery is not going to replace, it has replaced traditional open surgery. Thank you.
Thank you. And actually, when targeted therapy, immunotherapy came, still there was a role of chemotherapy. 70–80% patients still take chemotherapy. But then for the, actually against this actually, Dr. Sujay Gupta, he is the head of the Tata Medical Center, Kolkata. He is a uro-oncologist. He has done his training from UK and France, and as I know, he is the pioneer in establishing the uro-oncology department because and making it so successful.
Very good morning to all of you here, esteemed colleagues, seniors and junior students. I thank Apollo Multispecialty Hospital and Precision with Cancer Care Group for inviting me for this debate. And I welcome Dr. Adla to Kolkata, and he's indeed a formidable debater. Now, this topic is very well thought of. Robotic surgery is going to replace traditional surgery in genitourinary malignancy. With so many robots being commissioned across the country as well as in this city recently, there can't be a more relevant topic. Now, it's quite an open-ended statement, really. When is this going to happen? Where? Here, all over the world, and how? And if you look at the operative word here, replace, to take the place of, or especially as a substitute or successor. For any modality of cancer therapy, it has to be definitely better than the therapy, the predecessor therapy. It has to have comparable or better oncology outcomes, functional outcomes, and has to be applicable in the area where this health system is. We definitely know the benefits because a lot of you are not surgeons. I've put this slide up. The ones in the red are advantages of any minimal access surgery, but the robot does give us improved dexterity, very good vision, and smoother surgical performance. But it comes at a cost. There's a large initial capital investment and a cost of maintenance, and we cannot forget the financial constraints that are there for the health systems across the world. Then there is training required. And one other important point I would like to mention, because we deal with a lot of locally advanced disease, lack of sensory feedback. The main procedures that we do, as has been discussed by Dr. Adla, are these. But what about emergency surgery, which we are called upon to do? If traditional surgery is completely replaced, who's going to perform these emergency surgeries? unscheduled surgeries, complications, disasters during robotic surgery. Unless we have training and ability to perform this, who's going to do this? This is the procedure which has been done, the highest number by uro-oncology surgeons. And me having initially trained as an open surgery, I cannot agree the benefits of robotic surgery in this procedure. The views are fantastic, the prostate is deep down in the pelvis, and it is indeed a benefit for robotic surgery in radical prostates. But is it definitely better than traditional surgery? Yes, a paper was presented. There are a lot of evidence in the literature. Everywhere it mentions the number of surgeries have a direct correlation with outcomes. This paper confirms that the functional outcomes at 24 months are similar. However, they have cautioned against interpretation of oncological outcomes. Then again, there is a Cochrane database review referred to in the EAU guidelines, which says that there is no high-quality evidence to inform the comparative effectiveness of laparoscopic or robotic radical prostatectomies compared to open procedures. The urinary and sexual quality of life-related outcomes appears similar, and overall and serious post-operative complications rates appear similar. So that notion that robotic surgery is definitely better in all aspects may not be entirely correct. We do a lot of radical cystectomies. There are mainly two components. This is for the benefits of non-surgeons. One is the extirpative part, and one is where the extirpative part involves removal of the bladder, and the reconstructive part, the conduit or the neobladder. This is a single center experience, 10 years from Mayo Clinic. They found no definite evidence of benefit. You go on to multicenter, this is from the Dutch group, again the same. Did not show overall difference in complications or cancer-related outcomes. Then again, the Cochrane database. It also compares the open and robotic cystectomy, and they have mentioned that it is similar outcomes with regards to complications and oncology outcomes. Renal cell carcinoma, localized renal cell carcinoma, we have very, very competent laparoscopic surgeons who do a radical nephrectomy without any problems at all. So why would somebody engage a robot for a radical nephrectomy? I have put some CT scan pictures of a patient we have done recently. His BMI was 41. He has a 15 centimeter tumor involving the proximal renal vein, and the margin between the renal vein and the aorta was indistinct. We decided to do an open surgery, and we achieved negative margins. I'm not sure we could have done this with a robotic procedure. Partial nephrectomy, I agree with Dr. Adla that there is definite less morbidity with this procedure, but the oncological outcomes have been equal. Then again, a multicenter study, again the morbidity was less, but the oncological outcomes were similar. Penile cancer, for management of local regional lymph nodes, there has been a lot of recent discussion about robotic or laparoscopic procedures given the skin complications that we have, lymphedema, skin necrosis, etc. But if you look at the literature, the oncological outcomes are uncertain, and the results should be interpreted with caution. With regards to RPLND, another procedure where there is a lot of enthusiasm regarding robotic procedures, the conclusion from the literature is further investigation, safety, and long-term oncology efficacy of robotic RPLND is necessary. What about training? If traditional surgery is replaced, I've taken two pictures. The one on the left is actually the Hamilton Mealy published in 1861. And the one on the right is 2023 edition. Traditional surgery remains relevant, and we have to train the surgeons of the future with traditional surgery before robotic surgery is considered. This is the commonest robot that is commissioned in India. We have about 100 plus installations. If you look at the deployment of robot, it is mostly urban-centric. India is a large country. how do everyone have access to robotic surgery if we replace traditional surgery? No new modality is relevant without a discussion of the costs. In our hospital, the difference in cost of a lap radical nephrectomy with a robot-assisted radical nephrectomy is 80,000 rupees. Definitely important in Indian scenario. With regards to open radical cystectomy and robotic radical cystectomy, it's rupees 1.5 lakhs. That is the difference. Hospital stay, less than 2 days difference between the two. So this enthusiasm about less morbidity, I'm not sure is entirely correct. Health economics. Again, if you look at the expenditure that India does on healthcare, it's 3.27% of the GDP. If you look at the map, the majority of the world has less expenditure on healthcare. Robotic surgery is expensive. Somebody has to pay for it. The one on the left is the largest public health insurance scheme in the world. That is commonly known as the Ayushman Bharat. We have something similar in the state which you may be aware of. It pays 5 lakh rupees per family per year. One robotic surgery will wipe out most of that. Is this relevant in India? These are the two advertisements I recently noticed on one of the main arterial roads in the city. The picture on the left shows you cancer has a new hope. It is up to the audience to decide, has robotic surgery made that difference? That wasn't there. If you do a SWOT analysis of the discussion today, the strengths definitely in radical prostatectomy and partial nephrectomy, although competent laparoscopic surgeons would question that. But the weakness, what happens in the surgical crisis if we do away with traditional surgery? In emergency, in reconstructive surgery, what about the cost in many areas in the world, and also a learning curve? Opportunity is definitely wider applicability. There are Make in India robots, so the cost of robotic surgery comes down. It will be more easy to commission across wide groups of the population. The threat, overboard marketing. We should not forget a robot costs between 11 and 18 crores, and there is no harm in considering return of investment. And are we going to shift the surgeons of tomorrow without basic surgical skills into robotic surgery? There was a very good editorial in the Indian Journal of Urology a few years back, and they have not talked about replacement of traditional surgery with robotic surgery. They have said it's judicious use, and judicious is the word which is important. Sushrota described how the hand of the surgeon would be. Question is the hand of the surgeon being replaced? In my view, not yet. The conclusion, robotic surgery is excellent in appropriate cancers, patients, and disease. There is no evidence that is unequivocally better than traditional surgery in GU cancers. Extensive training facilities would be required. It is more expensive than traditional surgery. Hence, in resource-constrained systems, we have to think about it. And traditional surgery will always remain relevant. Thank you very much.
Thank you, thank you. I will ask Dr. Sanjay to have final 2 minutes. Anything?
I don't need that much. So, first thing, whenever we see any new technology, first we have to show that it is equivalent. I said it was equivalent. Dr. Gupta has said it is equivalent. That's the first thing. Second, is it slightly better with respect to perioperative care? And the answer is yes. Then the third one is the cost implication. Now there are 4 platforms that are robotic platforms that are available in India. If Intuitive was costing 100 rupees, the Indian made one costs 30 rupees to do it. So like minimally invasive surgery, which is the laparoscopic surgery, which has replaced the traditional open surgery, robotic platform is going to be the future. Whether it is Intuitive, whether it is Hugo Raz, whether it is SSI Mantra, that is another debate, okay? Then the fourth one is with respect to the training element of it. Every system will find its way. It is our responsibility to find its way. When we started doing lap radical nephrectomies in England, they said, oh, who will do the trauma radical nephrectomies? We never did trauma radical nephrectomies because the radiologists started getting the embolization things into place. We never did trauma radical nephrectomies. So that's the way. Once a system agrees that this is the standard of care, we will find a way around it. And the last thing, I do not want to be the BBC which says India cannot feed its poor. Why is it sending people into the space? It is my decision. It is my decision how I want to use my money. If we keep on doing open surgery, we will never aspire to be providing cutting edge, the best in the world. That's what we should not aspire. That's what we deliver as of today. Thank you.
Dr. Sujay?
Yes, thanks, Sanjay. We have to remember what our goal is. Our goal is cancer cure. Our goal is comparable functional outcomes. We are all going towards the same goal. Robotic surgery is another quiver and another arrow in our quiver. So we should not disregard one form of surgery for the other. All will remain. Thank you.
Any question, one or two from the audience? Any question? Thank you. Thank you.
So, sir, before we conclude the session, may I request, sir, please stay back, sir. So, may I request Dr. P.N. Mohapatra, sir, to hand over a memento to our debaters as a token of appreciation. First to Dr. Sanjay Adla, sir. And Dr. Sujay Gupta, sir. So we conclude our first session here. Thank you.